Over to David.
All right. Well, I'm going to show a case where I could have definitely done things better. You know, there are about 3 seats in the first 4 rows if someone wants to come empty seats from the back. So it's not advancing here. The keyboard is not advancing. So maybe let's try here. Okay, now it's advancing. All right. So this is a 64-year-old patient who was referred to me. They had a toric monofocal 6 months ago. And she has 2040 uncorrected. She had a history of a epiretinal membrane with a retinal detachment in this eye that had the monofocal. She's actually referred because of the anisometropia for cataract surgery on the other eye. So the left eye has been done. She's referred for cataract surgery on the right eye. All right, so you can see she's got this large anisometropia. She's 6 months post-op. She's 20/40. Now, she had a toric lens, but she's got a lot of cylinder in the first eye that's done. And the axis that it's at is the 180 axis. So, of course, I'm curious about that first eye. And look, the true axis, at least in the anterior cornea, should be at 45. So it looks like the lens isn't exactly aligned. And so that's why she's 20/20 with a diopter and 3/4 with a T4. So of course you can go, this is one of the online calculators, and what's nice is it not only will, because you input the post-op refraction, tell you where the lens should have been, and it matches up with that 40-degree axis, but look, it tells you that if you rotated it, this would be your refraction afterwards. So that's really one of the great benefits. So I guess I'm going to ask the audience, how many people would actually suggest rotating this lens? So after 6 months, so that's the question. All right, now that one person in the audience, how about my expert faculty? Who would go? It's 6 months out, and she's actually not referred for this.
Which IOL was used at Alcon?
I think it's an Alcon T4.
Single piece. I don't see much phimosis around, and there's not much of PCO. So I may still attempt to put in a viscoelastic separate there, because there is a good coverage all around. Yep. So if you get one edge, you will be able to open up this bag. And you don't need to open up because you need to rotate it anti-clockwise. These IOLs are a little difficult to rotate anti-clockwise. They are much easier to rotate clockwise. Right. In this case, you need to rotate it anti-clockwise if you need to go to 38. So, exactly. So I would like to put in a viscoelastic in the area till 180 to 36, and in the exactly opposite direction. You don't need to open the whole bag up. Still attempt to rotate it back. Only thing is, if the rest of it, then it will correct. I think it will be possible because I don't see much fibrosis.
All right. So we have one vote to, even though this is the eye to go in.
I would also try to rotate it by just opening up the bag by using a thin cannula and then visco cannula separating it, and then try to rotate it if I can. Yeah.
Only one thing, David, I noticed was there's some amount of fibrosis opposite to the 40 degree. So in the area of inferior whatever. So opposite to 40, there is some amount. I think the CCC there has gone beyond the optic.
Right.
And that's where it's fused.
David, why not just do a laser?
You mean of the cornea keratofractive? Yeah. Okay, so that's an option. Then you could leave it alone.
It's very less power. Is the -1 plus 1.7567. It would be easily correct, I thought.
So the first thing is, I think the timer is wrong, right? I have 12 minutes.
Yeah, you go
okay,
ahead. Yeah.
Okay, because we. So I think that the two things that are encouraging are if we could get it 140 degrees rotated, she'd be plano. And then the second thing is sometimes you see this fibrotic little small rexus at this point. This one isn't fibrotic. So I'm with you guys. I told her, I think if we rotated it, I think we could get you seeing a lot better. She said, okay. So I go in and I see these folds there. I said, did I miss something? But so I'm just here with lidocaine. And I said, yeah, no, that's the posterior capsule. And the lens is pretty mobile. We know with the Acrosoft, you have those terminal bulbs, and it might be fibrotic then. So I'm saying I'm going to go for it. So I think I'm going to, well, yeah, so I'm going to go for it. I'm going to put the viscoelastic in, and well, it opens up pretty well. Okay, so this is what Kumar was saying. Let's try to inflate it. Amar would have already finished the PRK by this point. And look at the left-hand side, though. I'm rotating it because I need to go 140 degrees now. And can I get that haptic free? Yup. It's pretty. Look down below. Did you see that?
Yeah.
All right. What did Gaurav, what did we see there?
There's look like the edge of the bag. I mean, there's some zonular.
You kind of saw like the equator of the
yeah,
bag,
exactly,
right?
yeah. Mhm.
Let's. You got to really look.
So it's a
There
loose-
it is. There it
It's a
is.
loose bag,
Okay,
yeah.
so all right. Well, but that haptic is free,
Put in the CTR.
and maybe I can rotate it. Okay, so this isn't looking so easy now. All right, so it's freed up. It's now worse because instead of 180, it's at 175 or 170. What would you do next? Audience? Hooks? Who would put in a CTR? All right, okay, so this is, I mean, I think that's going to solve it. Faculty? CTR? Yeah. Amar? Stop and do PRK. Amar's going to take it out and put in a glued IOL.
Amar says rotate it back to 180 and do a surface.
All right.
What I would
Yes.
do is like I would cut the haptics and place a new IOL in the bag.
Take it out, okay.
Yeah.
But it's not fibrotic, and remember that the beauty of that formula is you know it's the right power and the right toric power. It just is the wrong axis. Okay, but you would put in a spherical or a new toric?
A new toric.
New toric, okay. Well, I'm going to, do the CTR. I think that's all it needs because it looks like about, what, 3 clock hours, maybe 4 clock hours. And so I'm smart. I know I have to kind of, not have the capsule bag bended. I kind of lost it there. Here I'm just, okay, what are we seeing down to the left? That's the bag. Whoa, wow, that's more than 3 clock hours. So I got to stop, and let's stop and reconsider now. Okay, so that was not helping. So that's my. Look, I did what you told me to do. Now, what do I do? Now, there's one problem, right? Because when you put the CTR, it's pushing the bag to my right, and there's no zonules to counter it. So how many people, maybe I should insert it from the other end, so I'm pushing the CTR into the area of weakness, and that would, all right? How many people would try that in the audience? All right, okay, seems reasonable. How many people, you wouldn't try it, but you'd like to see what happens if I try it? Okay, that was the other half that didn't vote. Well, that seemed like a good idea, so I just turn it upside down, right? Because I don't want to make another incision. And let's see how this is going. It's not really bending. Maybe if I hook it, that's a little awkward. And it's kind of, well, I can't really see what's going on. And there's a haptic down there. That's not working. Okay, I'm not going to push that any further. Okay, so this patient came for the other eye surgery. The doctor referred for the other eye. And I've pretty much got 3 clock hours of zonules. I've decentered the lens. Can I just push it back and? Ask about Dr. MR, I'm going to refer this patient now to you. Yeah. So, all right. So I've kind of succeeded in. So this is about trying to figure out what our mistakes are. Now think about the way CTRs work, right? I'm aiming to the left. I know the ring is going to open to my right, and it's no problem here. There's a PXF with a bleb, and that's because the capsule is bending the ring and steering it in, okay? And that's what I thought I was just going to get away with in this case. Now, this is a case where I put in a 3-piece and the round rhexis became ovalized. Wait a minute, why would that happen? Yeah, thank you. Well, it's because there's 2-point pressure from a 3-piece lens, and if the zonules on the other side aren't strong enough, the point pressure from the lens deformed it. The round rhexis became oval. So I'm going to insert a CTR inside, and I do like inserting it this way, even though the haptics go the other, and watch what happens. This oval rhexis becomes round. So this demonstrates the mechanism of CTR. It's distributing forces equally to all 12 clock hours at the same time. So a nice demonstration of how the rhexis, the CTR works. All right, so now here's a case where I inadvertently grabbed the anterior capsule and I've created a 3 clock hour dialysis nasally on a pseudoexfoliation patient. So similar to this case, I think all I need to do is put in a CTR, right? So again, I'm just doing my cortical, oh my gosh, I created a dialysis. So what, 3 or 4 clock hours, and I know I want to try to bend the haptic, and it's kind of like this case. I'm seeing the entire equator. I don't see any zonules at all. Wow, I've got like maybe 8 clock hours there. And then look what happens, you know, that you trap the cortex with the CTR, but not only that, when I tug and strip the cortex, I'm stripping the zonules on the other 12 clock hours because those forces of stripping are transmitted to all the other clock hours. So the CTR now is making the cortical removal. I'm stripping as many zonules as I am the cortex. So this is where the CTR can cause, you know, a problem. So sometimes, you know, well, you know, so the better thing to do would have been what?
Capsule hooks?
Yeah, capsule hooks, because they're the artificial zonules. And now I know that it wasn't total negligence that I grabbed the anterior capsule. We often suck the anterior capsule when we're aspirating cortex, but the zonules keep it from being aspirated. All right, so this is what I should have done when I first saw that dialysis, is probably, you know, it costs some, it takes extra time, but as is often the case, I should have done this. These are capsule retractors in the United States. This is from Microsurgical Technologies. They are global. This is actually my modification called the CHANG. I have no financial interest. It's just a double-stranded nylon loop. We made the tip closed so the CTR won't go inside. And now see what happens. I have artificial zonules. And now it's a little, so something, it's still not going in. So let me try it one more time. I filled it with viscoelastic. You don't want to push too hard, right? Because you push it right through, and then all of a sudden something kind of gave and it went, and there it is. Okay, so now remember I have to dial it 140 degrees to get this lined up, and there we go, and it's moving now. And it's amazing that, so this is a great demonstration for you now of capsule retractors. Look at the difference between with and without the capsule retractors, just the simple rotating of the lens. So they're supporting the bag like artificial zonules, they support the AP direction, and then we're gonna take them out. Okay, we finally got the lens here, and I still haven't done the other cataract, which is why she was referred, but I'm feeling okay. There's no vitreous going around there. And anyway, so we take that out. All right, so this is the best part. I get the pupil to come down with the myocall. There's no vitreous prolapsing. Whew. This is doing something she didn't even ask for. Okay, so this is what I know now. But we didn't have this back then. And this became available in the United States last November. This is the spiral CTR injector from Corsa Cantina. Dr. Shimawaki from Japan invented this. And you see there's a fixed hook in the front to grab that lead eyelet. And then when I insert this in, instead of the capsular bag bending the CTR, that little fixed hook is what bends it. And that's why it's called a spiral. And so this is very ingenious. I keep injecting it. It doesn't put any pressure on the zonules, and you basically tilt it, and then the lead haptic falls off. You tilt it a little more, and the trailing haptic falls off. And this is what I now use for my CTR injector. You know, I showed you we had the capsule retractors here, and sometimes this will get tangled up in the capsule retractors, but look how nicely this spiral CTR injector does. So it's available through Catena Corsa, it's reusable, and I use this. Now sometimes it doesn't come off, no problem, you just knock it loose. All right. So, and this is from Dr. Shimawaki, and he has this nice demonstration. So when the typical CTR injection decenters the bag, but with the spiral injector, again, there's no contact with the fornix, and so we really, if we have bad zonules, we're not relying on the zonular integrity to insert that. So in this case, by golly, she got to 20/20 just as the formula predicted by rotating it. She was very happy. And she said, I don't even need surgery in the other eye because I'll just wear a contact lens. And I'm just thinking, now why do you think the doctor referred her to me for the second eye? Remember, this is exactly what the formula predicted, which is, you know, any thought on why the doctor referred her?
He's still your friend, no?
It's another doctor in Northern California. Yeah, maybe there was some problem with the original surgery.
Yes.
You know, and but there wasn't part of the referral letter, and in fact, it was referred for the other eye. You know. Yes, exactly. Now, what do you think happened in this case? So this is about mistakes and things. So I should have put in capsule retractors. I should have used a spiral CTR injector, which is now available, wasn't back then. Maybe I should have left the lens alone. Anything else? What was so different about this case? 6 months after surgery in a fairly young person. Have you ever seen so little fibrosis? So, the polishing, okay, yeah. Anyone in the audience have a thought on what's going on? It's very unusual, and it's on your dialysis. Yeah. Yeah, exactly, Shitra. So this is the dead bag syndrome, and I recognized it sort of afterwards, and this was only really reported in 2022, and we don't know what causes it. It may be just in one eye. But there's a complete absence of lens epithelial cells. There's no reaction, there's no fibrosis. It's associated with loss of zonules and even late bag IOL dislocation.
Does that happen so fast, dead bag?
Yeah, no one knows exactly when it happens. So these are the two. You can take pictures of this if you want to read more about it. And it's a mystery as to why it happens and when it happens. Sam Maskett first described this a number of years ago, and then this first study in 2022 was a series of them. And it's as though the lens epithelial cells just die.
They don't have it.
And so it's not really polishing too much or anything. They just die. And so you don't, and why would there be weak zonules and so forth? And as I think back on it, I can think of, I remember cases where I did a toric and it kept rotating around. Well, you go back, you get it and it lined up and it rotated again. And one of those patients came back and the whole bag was dislocated. She had dead bag syndrome. So this is a cause of a toric lens not staying where it's put. And had I known that it was a dead bag, what I should have done is probably put in capsule tension segments and sutured it, because she is at risk for late bag IOL dislocation. The case is already done. We'll just watch it and find out. So anyway, how many people in the audience have seen dead bag syndrome?
So many, all of us, I think.
Before you saw this video, yeah. So,
Yeah.
So
That's
David,
it.
I want to know whether this patient, when did the patient first report, or was it documented when she got that astigmatism? Like, was it right after surgery or
Yeah.
6 months after surgery?
Yeah,
Was it primarily
so I don't think
toric IOL?
this is the original letter, and the lens did not rotate. I think it was just, they got it as close, he put it in and left it.
Left it, yeah.
And I just figure, maybe
And
it
probably
rotated
the
or
primary
something.
surgeon had encountered some kind of zonular laxity
Yeah.
at the time of surgery as well, so he didn't try to position it perfectly, because when he was probably rotating it, he couldn't rotate it all the way.
Exactly. All right, thank you very much.